Management of age-related cataract and preoperative considerations. So what are the indications of cataract surgery? There are two indications. One is visual improvement, another is medical indications. Visual improvement is the most common indication for cataract surgery. An operation is indicated when the opacity develops to a degree sufficient to cause difficulty in performing daily activities. Clear lens exchange, which is the replacement of the healthy lens with an artificial implant, is an option for the management of refractive error. So it is for the refractive error. So clear lens exchange is only for the refractive error. And there is medical indications, those in which cataracts is adversely affecting the health of the eye, like paculitic, pacomorphic glaucoma. Cataract surgery improve the clarity of the ocular media. It is also required in the context of monitoring or treating fundus pathology. Now, systemic preoperative assessment. So for any elective surgery, a general medical history is taken and any problems managed accordingly. This table set out suggested further inquiry and action in relation to a range of systemic diseases. Like for example, in diabetic myelitis, the number one is diabetic myelitis, which is common. So further questions which should be asked in diabetic myelitis are: is diabetic myelitis well controlled? It will never blood test like finger prick test may be sufficient. Consider additional test if necessary. So diabetes will need blood test. So if control poor, may need to defer surgery and contact patient's physician. Medication and food and drink intake is usual on the day of surgery for local anesthesia. And there is systemic hypertension. So if systolic is more than 170 or diastolic more than 100, may need physician opinion. Consider contacting physician for optimization and defer surgery if necessary. And there is actual or suspected myocardial infarction in the past. So note the date of the MI and defer surgery for 3 to 6 months from the date of MI. Contact physician anesthetist if concerns about current cardiovascular status. And there is angina. So ask if it is stable or well controlled. Bring glycerol trinitrate spray on the day of surgery. And if unstable, contact physician or anesthetist. So glycerol trinitrate spray is necessary. Respiratory disease, ask about chest function currently optimal. Can the patient lie flat? Now if the patient cannot lie flat, may need to discuss with operating surgeon. And trial of lying flat at least half an hour. Chest function should be optimized as far as possible prior to surgery. Remind patient to bring any inhalers to hospital. And there is leg ulcer or other skin wound. So ask about it is acute or chronic, and evidence of active infection. Surgery should be deferred until active infection has resolved. If healing is not possible, for example chronic leg ulcer, the lesion should be covered with a sterile dressing during the perioperative period. A preoperative wound swab or culture and prophylactic oral antibiotics may be considered. And there is rheumatic fever, transplanted or prosthetic heart valve, previous endocarditis. So ask, does the patient usually require prophylactic antibiotic cover for the operations? Antibiotic prophylaxis is only exceptionally required for ophthalmic surgery. For example, removal of an infected eye. And there is stroke in the past. So date of the stroke should be noted. Particular residual difficulties. Defer surgery for at least 6 months from date of stroke. Many have positional other practical consequences. And there is rheumatoid arthritis. Rheumatoid arthritis. Does the patient have any problem lying flat or with neck position? If in doubt about patient ability to position appropriately, may need to discuss with operating surgeon. Intubation for general anesthesia may be more difficult in some patients. Another condition related to cataract surgery is jaundice or non-viral hepatitis in the past. So ask about what was the underlying diagnosis, and if viral hepatitis suspected, note prominently as special precautions to avoid needle stick injury may be necessary. Another condition is HIV infection. HIV infection, if there are any high risk factors, has the patient undergone an HIV test in the past, special precautions to avoid needle stick injury may be necessary. And there is sickle status. For patients of Southern Asian and Afro-Caribbean ethnic origin, inquire about sickle status. Blood test if unknown in general anesthesia is planned. There is Parkinson disease or other cause of substantial tremor. So is the patient able to maintain head stability sufficiently to cooperate with local anesthesia and surgery? If not, may require general anesthesia. So another is epilepsy. Is the condition well controlled? Ask, and general anesthesia may be preferred. And there is myotonic dystrophy. Has the patient undergone surgery or anesthesia in the past? If general anesthesia is planned, an anesthetic opinion should be obtained well in advance of the surgery. So, systemic preoperative assessment, routine preoperative general medical examination, blood test, ECG are not usually required for local anesthesia. If general anesthesia is planned, assessment is according to local protocol. For example, general examinations, urea and electrolytes, random blood glucose, full blood count, ECG. An anesthetic opinion may be considered for chronically unwell patients and those with complex medical problems. Ask about current medications. It should be recorded. This will often guide general medical assessment. Medications relevant to eye surgery include systemic alpha blockers. For example, tamsulosin. They are commonly associated with intraoperatively floppy iris syndrome. Management of anticoagulant therapy or an antiplatelet agent. It should follow local protocol. Most surgeons do not stop antiplatelet drugs for cataract surgery, though this may be preferred for oculoplastic procedures and glaucoma surgery. Anticoagulation status, usually expressed as the international normalized ratio INR level. It should be within the therapeutic range appropriate for the individual indications. For example, usually higher for heart wall thrombosis prophylaxis than following deep vein thrombosis. A common approach is to check the INR within 24 hours prior to surgery in stable patients. Another is allergy. Allergy history. True allergy rather than intolerance should be confirmed. Medication including sulfonamide, antibiotics, commonly used for following cataract surgery. Iodine or shellfish. Shellfish may indicate an iodine allergy. If allergy to iodine is present, an alternative skin and conjunctival antiseptic such as chlorhexidine should be used. Others, for example, allergy to latex, then latex-free gloves may be necessary. Sticking plaster, local anesthetics, insect bites, because there is cross-reaction with hyaluronidase. It is often used with local anesthesia. And there is methicillin resistant staph aureus carriage. So relevant national and local protocols for identification and management of patients at high risk for MRSA carriage should be followed. And there is transport to hospital and to the operating theatre. Within hospital, special arrangements may be needed for patients with poor mobility or exceptionally high body mass. For urgent or emergency surgery, medical risks should be assessed individually and according to circumstances. So, the important is systemic alpha blocker, stem solution. They are the main cause of intraocular floppy iris syndrome when undertaking phacoemulsification. Now, before the surgery, ophthalmic assessment should be done in detail and pertinent ophthalmic evaluation is required. The following points should be considered. First one is visual acuity. It is usually tested using a Snellen chart. The next is cover test. A heterotropia may indicate amblyopia, which carries a guarded visual prognosis, or the possibility of diplopia if the vision is improved. So cover test is necessary because it carries a guarded visual prognosis if there is heterotropia, or the possibility of diplopia if the vision is improved. A squint, usually a divergence, may develop in an eye with poor vision due to cataract, and a lens surgery alone may straighten the eye. So a squint, usually a divergence, may develop in an eye with poor vision due to cataract, and lens surgery alone may straighten the eye. Third is pupillary responses. Because cataract never produces an apparent pupillary defect, its presence implies substantial posterior pole pathology. So always check pupil responses. Fourth one is ocular adnexa. Decrucistitis, blepharitis, chronic conjunctivitis, leg ophthalmus, ectropion, entropion, tear film abnormalities may predispose to endophthalmitis. These conditions should be dealt before intraocular surgery. Next is corneal assessment. Eyes with decreased endothelial cell counts, for example, substantial corneal guttata, have increased vulnerability to postoperative decompensation. So, specular microscopy and pachymetry may be helpful in assessing risk, and precautions should be taken to protect the endothelium. A prominent arcus sinalis is often associated with a surgical view of decreased clarity, as are stromal opacities. The next point necessary is interior chamber. A shallow interior chamber can render cataract surgery difficult. So, recognition of a poorly dilating pupil allows intensive preoperative mydriatic drops, planned mechanical dilatation prior to capsulorhexis, and or intracameral injection of mydriatic. A poor red reflex compromises the creation of a capsulorhexis. But can be largely overcome by staining the capsule with trypan blue. So always take trypan blue before surgery. It should be on board. Lens. Next point is lens. So nuclear cataracts tend to be hard and may require more power for phacoemulsification, while cortical and subcapsular opacities tend to be softer. Black nuclear opacities are extremely dense, and extra cap cataract extraction rather than phaco may be preferred option. Sod exfoliation indicate a likelihood of weak granules. For example, phacodonosis, lens wobble may be present, fragile capsule, and poor mydriasis. Another important is fundus examination. Pathology such as age-related macular degeneration may affect the visual outcome. Ultrasonography may be required principally to exclude retinal detachment. Ultrasonography may be required to exclude retinal detachment and staphylomas in eyes with very dense opacity that precludes fundus examination. Next point is sclera. If a prominent explant encircling band has been placed during prior retinal detachment surgery, or if the eye is particularly large or the sclera is thin in high myopia, peri and retrobulbar local anesthesia should be avoided. Current refractive status. Last point is, it is critical to obtain details of the patient preoperative refractive error in order to guide IOL implant selection. The keratometry reading obtained during biometry should be noted in relation to the refraction, particularly if it is planned to address astigmatism by means of targeted wound placement. A toric IOL or a specific adjunctive procedure. So, it is particularly important to obtain a postoperative refractive result from an eye previously operated upon so that any refractive surprise, even if minor, can be considered. So, careful preoperative examination of the posterior pole is needed in a patient requiring cataract surgery to exclude unrelated pathology that may affect the final visual result. Next important point is informed consent. It is essential that the patient arrives at a fully informed decision before proceeding with cataract surgery. As well as discussing the benefits, risks should be conveyed at a level appropriate to each patient levels of understanding, with an explanation of the more common and severe potential problems. Points for discussion with the patient may include: Number 1. Most cataract operations are straightforward with good visual result. Most complications can be dealt with effectively and cause no long-term difficulties. But some rare problems can be very serious. In about 1 in 1,000 cataract operations, the eye will be left with a little or no sight. In about 1 in 10,000, the patient will lose the eye. Some complications mean that a second operation will be necessary. A relatively mild and usually easily treatable but common complications include periocular ecchymosis, allergy to the eye drops, IOP spike, iridocyclitis, posterior capsule opacification. Moderate and severe but less common complications include posterior capsule rupture, vitreous loss, 1% or less per experienced surgeon. Higher for trainees depend on experience. Zonular dehiscence is a complication. Drop nucleus about 0.2%, leaking wound, sustained macular edema, corneal decompensation sufficient to need corneal graft, unexpected refractive outcome, may need contact lens wear. Lens implant exchange or corneal surgery, retinal detachment in less than 1%, IOL dislocation, persistent ptosis and diplopia. These are the complications. So these should be discussed. Rare but invariably very serious complications like endophthalmitis in 0.1%, suprachoroidal hemorrhage in 0.04%. Also, the risk of anesthesia should be conveyed by the person administering it. Local anesthesia carries a low risk of problems. Some rare complications have the potential to be very serious, including loss of the eye and even death. Allergy to the anesthetic agent, retrobulbar hemorrhage, allergy and retrobulbar hemorrhage, perforation of the globe and inadvertent infusion of the anesthetic agent into the cerebrospinal fluid via the optic nerve sheath causing brainstem anesthesia. There is virtually no risk to the other eye. Sympathetic ophthalmitis is extremely rare, following moderate cataract surgery. The next important point is biometry. Biometry facilitates calculation of the lens power likely to result in the desired postoperative refractive outcome. In its basic form, this involves the measurement of the two ocular parameters, keratometry and axial anterior-posterior length. Keratometry. Keratometry involves the determination of the curvature of the anterior corneal surface. One is steepest and another is flattest meridian, expressed in diopters or in millimeter of the radius of the curvature. This is commonly carried out with the interferometry apparatus used to determine axial length. But if this is unavailable or unsuitable, manual keratometry, for example, Jewel Shart's keratometer or corneal topography can be performed. And there is OCT, optical coherence biometry, not OCT. It is a non-contact method of axial length measurement that utilizes two coaxial, partially coherent, low-energy laser beams to produce an interference pattern, partial coherence interferometry. Modern biometry devices also perform keratometry, anterior chamber depth, and corneal white-to-white measurement, and are able to calculate IOL power using a range of formula. Measurements have high reproducibility and generally require less skill than ultrasonic biometry. Next is A-scan ultrasonography. The slightly less accurate method of determining the axial dimension and can be acquired either by direct contact or more accurately but with great difficulty by using a water bath over the eye, that is immersion ultrasonography. The sound beam used must be aligned with the visual axis for maximal precision. Each reflecting surface is represented by a spike on an oscilloscope display monitor. Next is IOL power calculation formula. Numerous formulas have been developed that utilize keratometry and axial length to calculate the IOL power required to achieve a given refractive outcome. Some formulas incorporate additional parameters such as anterior chamber depth and lens thickness to try to optimize accuracy. The SRKT, Haggis, Hoffer Q, and Holiday 1-2 are commonly used. Specific formula may be superior for very short, possibly the Hopper Q, and long eyes. But opinions vary. It is very wise to plan individually for unusual eye. So for short eyes, very short eyes, the Hoffer Q. So consulting the latest research and recommendations. Short eyes in particular are prone to unexpected mean spherical error Pauling surgery. Another important point is previous refractive surgery. Any form of corneal refractive surgery is likely to make a significant difference to the IOL power required, and standard IOL calculation are unsuitable. Several different methods have been described to address this situation. Most involve the calculation of the post-refractive procedure true corneal power using a special process, refractive history method, contact lens method. An insertion of this into a standard Hoffer Q or specific Muscat formula. But the Haggis L regression formula uses statistical data to facilitate calculation on post-refractive surgeries using only standard input. It may be prudent to utilize more than one method of IOL calculation. The patient needs to be warned that an under or overcorrection may follow the surgery. So there are two formulas, Hoffer Q and Muscat, and another is Haggis L. Contact lens. If the patient wears soft contact lens, these should not be worn for up to a week prior to biometry to allow corneal stabilization. Hard and gaze permeable lenses may need to be left out for 2 weeks. Another point is personalized A constant. Consistent postoperative refractive deviation is found in most of an individual surgeon's cases. It is assumed that some aspect of personal surgical or possibly biometric technique consistently and similarly influence outcome. A personalized A constant can be programmed into biometry apparatus to take this into account. So to achieve accurate preoperative biometry, contact lenses should not be worn for 1 to 2 weeks before the measurements are taken. Next point is postoperative refraction, in which the first one is emetropia. It is typically the desired postoperative refraction. Those spectacles will be needed for near vision. Since a conventional IOL cannot accommodate, many surgeons aim for a small degree of myopia, about -0.25 diopter, to offset possible errors in biometry. Postoperative hypermetropia, which necessitates correction for clear vision at all distances, is less well tolerated than myopia. So, hypermetropia postoperative is less well tolerated. And there is contralateral eye. Contralateral eye postoperative refractive planning must consider the contralateral eye. If this is a significant refractive error but is unlikely to require cataract surgery within a few years, the postoperative target for the operated eye might be set for within less than 2 diopter of its fellow to avoid problems with image size discrepancy and difficulty with binocular fusion. In some cases, such as when there is early lens opacity in the fellow eye or when ametropia is extreme, the patient can be offered lens surgery to the other eye to facilitate targeting both at emetropia. Another point is postoperative refraction point is monovision. It is a concept in which the usually non-dominant eye is left with between 1 and 2 diopter of myopia to allow unaided vision for reading, whilst emetropia is targeted in the dominant eye. This is attractive to some patients, generally those who have previously been using contact lenses or spectacles to achieve monovision. Another point is multifocal lens. This option uses a variety of optical means to achieve satisfactory near distance and intermediate vision. Most patients are satisfied with the result, but significant numbers are unhappy, complaining of phenomena such as glare and loss of contrast sensitivity, high accurate refractive outcome including limited astigmatism are necessary for optimal function and a great likelihood of tolerance. The last one is younger patients. With a conventional monofocal IOL, patients younger than about 55 years need to be aware that they will experience a sudden loss of active focusing and that it will often take some time to adjust to the loss of unaided near vision. So patients younger than 55 need to be warned that active focusing will be lost after the implantation of conventional monofocal IOL. Intraocular lenses. So first one is positioning. An IOL consists of an optic and haptic. This is optic and this is haptic. The optic is the central refractive element and the haptics, the arms or loops that sits in contact with the peripheral ocular structures to centralize the optic. Modern cataract surgery with preservation of the lens capsule affords positioning of the IOL in an ideal position in the bag. So you can see here in the bag positioning. Complicated surgery with rupture of the posterior capsule may necessitate alternate positioning in the posterior chamber with the haptics in the ciliary sulcus. A 3-piece IOL only, not 1 piece, including those with plate haptics, or these may not be stable. Or in the interior chamber AC with the haptics supported in the angle. AC positioning requires a specific lens type. In some circumstances, a supplementary IOL may be placed in the sulcus in addition to the IOL in the capsular bag. For instances, to address a residual refractive error following primary surgery, secondary pseudopolyphakia. It is known as secondary pseudopolyphakia, and thin profile IOLs are available for this purpose. It is preferable to avoid a secondary sulcus IOL. It is known as primary pseudopolyphakia. To avoid a secondary sulcus IOL in very short eyes, in nano-ophthalmic eyes, due to risk of angle closure. Off-the-shelf IOL of a power of 40 diopter available, and custom IOL can be produced in even higher powers. Design. First one is flexible IOLs. Flexible IOLs introduced into the eyes via an injector and subsequently unrolled inside the eye are now in general use. Injector-based delivery utilizes a very small incision, also allow avoidance of the implant contact with the ocular surface, so reducing the risk of bacterial contamination. So simply folding up the IOL is an alternative, but require a slightly larger incision. Flexible materials are discussed below. There seems to be no distinct superiority of one material over another. The first one is acrylic IOLs, hydrophobic, in which the water content is less than 1%, Acrylic materials have a greater refractive index than hydrophilic lenses and are consequently thinner, though this can result in dysphotopsia, troublesome glare and reflections.